And the other thing is, I think in the phase 2, the mindful, they don't have a threshold for inflammation. Like I think whereas in the phase 1, they were trying to, say the ESR has to be a certain amount or CRP. I don't remember seeing that. And presumably if this is like an inflamed cohort of patients, that might be an issue.
One more time?
Mindful study, the phase 2.
Yeah.
When I was looking at the inclusion criteria, I don't think I saw anything about having an elevated ESR or like inflammatory biomarkers.
Isn't that the whole point?
Yeah, exactly. And so I was wondering, is that just so that they could increase enrollment in their study? Because it looked like for the phase 1, they did have that.
Yeah, I don't know. They don't have an IND. There's no US study sites.
Yeah, it's not US.
No IND, I'm guessing?
I did not see one, but...
that's usually not a good sign.
Isn't that like AVXL too, where they did it all outside the US?
Yeah. So you got 24 weeks, which is, like a blink of an eye.
Yeah, that's the thing is, I don't know if that's fast enough to pick anything up. All the like donanemab and other studies are like 76 weeks.
Yeah, but did donanemab separate at 24 weeks is the question.
I think it just starts. I was looking at those curves, and I think just at 24 weeks it starts to separate.
Somebody said they're at clinical hold in the US.
Well, I know they had a CRL for manufacturing of XPro. I don't know if they ever got that back.
Yeah, that's probably
got that resolved.
Somebody says donanemab was stat sig at 24 weeks. But donanemab study was also 1,000 patients or something, right?
It was, yeah.
I was wondering, do you think like that you tweet about the adverse effects like IMNB trial? You think it's like because like their core approach is fundamentally flawed, or due to like
yeah. But I mean, when companies design drugs, they try to use some kind of, they sort of form a target in mind, a biological target that they hope that their drug will have an effect on, which will in turn have an effect on the disease.
Do you think like with like the market, you think it's like already priced into the adverse news, or there's still like room to move?
So they have these results coming up, and the results will either be good or be bad or be indifferent, and we'll find out in a few weeks. Markets are very effective at pricing things in, right? And the market is pricing in basically a 1% chance of the drug working, because a good Alzheimer's drug is worth billions. And this company's stock is not worth billions, it's worth a fraction of that. So the market is telling you there's a very, very low chance of probability, but the market's not always right.
So like I could use like the market as like a factor to determine like not the probability, but like the likelihood of some said company working out.
Yeah, so I think the company's approach is flawed. I doubt the drug works. I have a pretty good handicap on these things. I'm usually right. You could call me the Steph Curry of biotech if you want to. I'm not saying you should. I'm just saying if you called me that, I wouldn't object to it. But I think that you can spot when a drug is poorly designed and doesn't work. And like cassava is a good example. Galectin was another good example. And this is a pretty good example too. Yeah, it'll be 1,000x if it hits, maybe even 10,000x, maybe even 1,000,000x. I see a lot of, people lined up at the grocery store buying lotto tickets too.
Yeah.
Seems like the people who write the lotto tickets get the upper hand on that.
And this one, isn't as much, with Sava, it was really that semiphilim and filament A really have no role in the disease.
I don't think TNF alpha has a role in the disease either.
That's what I think. Yeah, yeah, exactly.
Yeah, it's funny because the transmembrane thing is like missing the forest for the trees. The first thing you have to worry about is Alzheimer's an inflammatory disease? Is it an autoimmune disease? Is it perhaps a protein misfolding, proteasome, Golgi, endoplasmic reticulum disease? Is it a lysosomal problem disease? Is it what do we know about this disease? And the answer is not a lot. We do know prednisone, which reduces TNF by 80%. you would think that would be, a good thing, but that doesn't work. In fact, it seemed to make cognition worse. The TNF alpha inhibitor etanercept didn't work. In fact, nothing seems to work for Alzheimer's, which is not a good start. So you really have to dance on a pinhead to sort of even form a thesis that you could believe in, which is, well, the dominant negative TNF somehow gets access to the blood-brain barrier, forms heterotrimers. Those heterotrimers stop TNF alpha signaling for TNF-R1, but they allow TNF-R2 signaling to take place, which is the immunity you want, even though it can't induce apoptosis because there's no death receptor. It's still going to be useful somehow. Oh, and by the way, if you knock out TNF-R1, you don't get Alzheimer's. So there are humans who have TNF-R1 knockouts. They have no cognitive phenotype. They have an autoinflammatory phenotype, but they don't have a cognitive phenotype. My guess, in fact, is that this drug will make things worse. But you do need apoptosis and necroptosis. In fact, you may need more of it in Alzheimer's disease state where you're trying to gobble up these, these neuritic plaques and tangles and things like that.
Yeah, and the whole TNFR1, TNFR2, like the TNFR2 being protective and kind of juxtacellular versus paracellular. I think if you just knock down TNF, that should help. And you don't see that with prednisone. So it's almost a moot point that they're just honing in on, we're just doing the bad TNF side of things. When inflammation is not even a prominent feature of the illness.
I don't know. I feel like, there's a lot we don't know. And that's always the risk of a short seller. You don't know what you don't know. And you just have to sort of make an educated guess and you hope you're right. And the rest is left to fate. But one of the things I want to talk about is PK. They've said that they did do some kind of CSF and analyte. They tested for this drug in CSF.
Yeah, this thing Aquaman is more of an expert in. He had mentioned that and I think he's out of town, but the O-link assay, I think, reacts with XPro, I guess, because it's this dominant negative molecule, so it will maybe link to the TNF part of that assay, and then you can kind of detect it in CSF. That's my understanding of how they are able to measure it.
Okay, so PK is something I've done a lot of. You take the sample, you run your assay. Again, it's hard for me to imagine why you wouldn't publish this or show the dose response in a corporate presentation. There's just nothing there. All we got is this weird, 1 mg per kg O-link result, which we don't even know if they did it right, but.
Yeah, with a phase 1, these are the things you're measuring, the PK, all that data, but they didn't give us any of that.
Yeah. It also doesn't look very good. 15% average cytokine reduction isn't exactly what I would write home about. You should be getting 50 to 80, maybe even 90%. These are all cytokines we know and love. IL-6, IL-2, IL-6 moving 5% is what? What's happening here? This isn't I wouldn't put this out as something good. How is this good? 15% is just normal human variation,
variability. Yeah.
What the fuck?
And there's no standard deviation on those. I don't see anything.
There does appear to be an error bar.
Oh, you mean on the one on the left there?
On the composite, yeah, but notice
you're calling it a composite. I see. So who knows?
Notice that it includes confidence interval above 0.
Basically, it's not statistically. It hovers at 0.
Yeah, I feel bad. I feel bad every time one of these happens, but it's also Biotech is a total disaster, partially because of overfunding. The hedge funds and mutual funds and VC funds, they just have to stop investing because all these companies are way overcapitalized. And Vivek's, got this issue as well.
Yeah, isn't that what's been going on recently? I've been following on Twitter all the companies that are kind of, they have a bad trial. They have all this excess cash, and then they have these horrible pipelines, and they just want to keep getting their salary, keep the lights, keep living that lifestyle with other people's money and not just return the money back. Like your other stuff doesn't work and it's not good.
Well, salaries, fat salaries and bonuses and other perks are really too good to ignore. I mean,
Right.
Everybody, maybe for everybody else, but not for me. That's usually the strat. But I think we'll get the answer in what we have. We have tonight, Wednesday, Friday. So it's 3 days left this week, including their interceding evenings and mornings. And then we got 5 days next week, and then 1 day the week after that, right?
Yeah.
It'll probably happen that one day, right? The last day of the month is my guess. One of the things that I've been interested in is, for a long time, quite frankly, but reawakened my interest is steroid receptor, glucocorticoid receptor, and how does it work? Still pretty mysterious. And TNF is also mysterious. The genes that glucocorticoid or steroids, repress and enhance are pretty much overlap with TNF. So, because it is literally one step downstream. So it doesn't really make sense that, prednisone, and also, you haven't seen industry spend much time or interest in autoimmune thesis or in autoinflammatory thesis of Alzheimer's, partially because COX-2 didn't work. NSAIDs don't work.
Well, the TREM2 is kind of this microglial, and that's failed. So
steroids
there was some money.
TREM2 was like the one, maybe let's try it again. It didn't work either. Like there's been several angles of, that tried autoimmune, autoinflammatory here. I personally like the thesis. I actually do think there's a lot of that happening in Alzheimer's, but I think you got to do VLA4 or integrin alpha 4 beta 7. I think you have to stop integrin trafficking. That's the real dangerous stuff. I think you probably want TNF intact. And the immune system's so complicated. I think the people who are long it are just like knuckle dragging mouth breathers that are like, TNF bad. Block TNF. And it's really way more complicated. And
absolutely,
I put up the what's the Japanese group, the KEGG, the KEGG maps. And I'm like, here's the immune system. There's 600 nodes here. Why do you think you got the right one? And they're like, oh, good point. It's like, you think there's not a lab? Every single node, every single protein has like 6 labs that claim that's the protein. That's the one. That's going to save it all. In fact, every one of these O-link targets, there's somebody out there who's saying, make a drug against this, you'll save the day. But, it's just a lot of it's guesswork and serendipity, quite frankly.
Yeah, and the only drugs working are the alpha beta misfolding and, these aggregations of protein clumps. That's the only thing that's barely worked. And that I think has to say that other things are not maybe as important as that. And maybe preventing that earlier in the process would help as well.
Yeah. Well, what's left on your list to work on?
I was trying to find, you had found some nice things with TNFR1 and 2 in the CSF and whether, that's elevated in Alzheimer's versus normal controls. Because if that's a driver of disease, you would expect elevated levels of these receptors. And you don't really see that. There's a couple papers that say there are some papers that say they're not. I just think mechanistically, this doesn't make sense to be playing a huge role in Alzheimer's disease. So whereas with SAVA, there was, from just base level, there was no reasonable chance this drug worked. Or even you, because you did the whole modeling and found that there's nowhere for it to even bind. Filamin is not even important. The drug doesn't even bind anything relevant. This one, it seems like it's just an accumulation of, the basic science didn't really pan out. The preclinical data with the mice don't really work out. And then the human data is horrible. So I don't know what that nail in the coffin will be.
Well, we don't know the human data is the problem.
What's that?
Is it horrible or we don't know it? It's a little bit of both.
We don't know it, but if they're not disclosing, like, I want to know what were the mini mentals on all those patients.
Sure.
Which of those patients were the low dose and which were the high dose? If there were 9 patients left and 6 of them were high dose, there's 3 that are, low or medium dose. What were those scores compared to the high? They don't give any of that data. Then they hone in on white matter, like MRI imaging, to show neuroinflammation, which is like a novel biomarker that hasn't been validated, and hone in on this arcuate fasciculus with 40% decrease in inflammation. Arcuate fasciculus, that's like for like language. That has nothing to do with like memory or what I would expect the issues to be in Alzheimer's disease. So they just like cherry pick whatever looks great by random chance in like 2 or 3 patients and hone in on that. It's very suspect.
What about this CSF phospho-tau 217?
Yeah, I'm trying to find that in my little deck here.
It declined by almost a log.
Yeah, there's no placebo. And I assume those are the 6 patients that made it to the end of the study. And is that JAMA paper? I feel like I had looked at that. Was that just a poster or?
Yeah, it's a study on phospho-tau 217. I like this. XPro improves synaptic function. Wow, that's quite a claim. That is quite a claim. They also only have week 4 data there. They just don't know how to present data.
On that proteomics analysis?
No, EEG alpha power.
Oh, okay.
But it's like, bro, like...
Oh, yeah, they had some other abstract or recent thing where they looked at synaptic proteomics and looked to see what was up and what was down. And again, it was very suspect.
Yeah, I think that it mostly is a company that doesn't look like they know how to like submit stuff for publication or like put together a presentation and that investors would care about. It's either that or like they're being malicious. And Aquaman, I think, thinks they're being malicious.
Mm-hmm. They had some webinar where it seemed to suggest they were gonna be forthcoming with the data. They were kind of like, we're gonna see the results, and like, doesn't work, it doesn't work. We're like moving on. That's what at least they claimed.
Yeah, I mean, I'm not sure what that means, right? Like, I have to look back at the phase 3s.
What was that, the phase 3?
For Coronado, his last company. Yeah, did they, like, I have to look at who's on the board and stuff like that, too.
Yeah, so I guess I still have, that's work to do then. Because, who are these characters?
That's my thesis. $1 million financing to launch what? Hyperliquid cryptocurrency? Oh my God. Reserve strategy? INmuneBIO? This used to be a drug company. Why do you want to short it? I think this could be long. These things work for a few minutes and then they fail. Yeah, it's a shame none of those guys want to chat and learn how to actually do this.
Yeah, it's the type of people who are going along the stock. They just have some cognitive guardrails, but it's always great learning from you. So thanks for doing this.
No, it's my pleasure. Yeah, one of the things about medicine that I've learned over the years is that you can't, it's very, very hard to design a drug that works. And if you are going to design a drug that works, it really can't be random. Like there's just a really limited ability for drugs to just work on their own. Just, all of a sudden have efficacy without being like really precision designed to do so. The old days of like serendipity in medicine are more or less gone. So to me, I wouldn't advance an Alzheimer's drug into phase 2 unless one, the phase 2 is remarkably large. Got me a lot of information on dose range. Got me some really good biomarkers. It was a really long-term study, like at least a year. And one of the best ways to learn if your drug doesn't work is through lack of a dose response. If at any point your dose response does not look normal, your drug doesn't work. And that's something that a lot of people kind of miss. So I think that there's a big benefit to, like, when Biogen did the lecanemab phase 2, it was like 800 patients, really long term, lots and lots of doses. And, they got a good sense for target engagement. If you're not engaging your target, then what are you doing? And I feel like that panel that they show is actually really bad. Like I would not show that if I were them. I'd go back to the drawing board. Like, I need to see a dose response. Like, why don't they show, well, they kind of do in that little side thing. They show this really weird, let me pull it up. Let me zoom in on it, super zoom. But like, if CSF inflammation is what Alzheimer's is all about, which is like a really tenuous claim, having a really hard time seeing that this is a 15% reduction. Feels like you should push this dose. So this is what you're trying to reduce, and you feel at 1 milligrams per kilogram, you've fully engaged the target. Well, showing this O-link, you haven't fully engaged the target.
Right.
Most of these things aren't moving at all. You think a 10% change in cytokines is going to change Alzheimer's? No. Alzheimer's is going to require, like, it's funny, amyloid, people worried that like reducing amyloid by 90% isn't enough. You have to reduce it by like 99%. and that's why donanemab and these other drugs aren't working that great, because they just...
Right, the brain shuttle. Yeah, Roche is spending all this money on getting more of this stuff into the brain.
Yeah.
Because they want 99%.
And you see that in things like prostate cancer, where you really do need to sop up all the testosterone. You need to like completely eliminate it.
Yes.
Like, what's the biggest mistake that you see biotech companies make when they think a drug should work, but it doesn't?
I don't know if there's a lot of those. I mean, I think that probably the biggest mistake is like when you're a small company and you don't want to give up. That happened a lot with, say, Cassava and others. Like, there's pride of authorship. I mean, if you make a drug and you design it and you say, this is mine, it's really hard to walk away from it often. And I think you have to be twice as like critical. So I invented this drug called RE024, I think. And that was the code name. And I was really critical of it. In fact, before I left the company that I started, I basically said that this drug's not going to work. It needs to be redone. But I think the problem is that there's this agency problem, owner-agency conflict, which is the first thing you learn about in any business textbook, which is that the managers of the organization and the owners of organization have two different goals. And this is a problem that's been ever present in business. The goal of the managers is to perpetuate what's best for them using the organization. The goal of the owners is to perpetuate what's best for them using the managers who work at the company. But so often the managers say, well, what would be better if we gave up on phase 1 and went back to the drawing board and did a whole bunch of science, our stock would take a hit and we'd have no news for 3 years. But it's a lot more exciting to potentially do, just rush forward with with the data, and maybe we get lucky, but at least we get our salaries and things like that. Nobody's going to fire us.
How can they kind of cherry pick or present the data in a way to make it look better? Because that's showing that
that mine's from baseline. So from baseline, this doesn't even make sense. One, there's no need to use log changes, right?
Right. You just go percent change. Yeah.
This looks just like somebody who didn't know what they're doing.
That's from one of their presentations.
It's kind of conflicting with the thing you showed.
Yeah, this picture here. That's the exact same data, but how are they?
It seems to conflict because
they removed the low dose. They're just looking at high dose, and they're showing the 50%. Okay, so they're now just honing in on the 1 mg/kg, and they're just saying here's baseline and here's 12 weeks, and it went down what, 50%?
Yeah, but how is that, like, what is the minus 2.2 log? 2.2 log is 99%. Minus 3 log is 0.999. So I just don't get it. You know, like, they actually went down 40%. But what's really bizarre, Z, is that the 0.3 mg/kg went up. And this just this data just says this is an uncalibrated experiment. Like, this is terrible because there's no placebo, right? And Lord knows what happened to the 0.6 mg/kg group. God only knows what that data is. But I assume that one makes it even more inconsistent. You know, at 0.3 mg, somehow this drug makes you much sicker, but it's simply 3x the dose. It makes you much better. You just throw this away and say this is worthless. I mean, it doesn't take a genius to figure out this is a long shot, which is what I really like about the Discord, because they're like, oh yeah, you must be an idiot, you don't like the stock. And it's like, well, listen, I gotta tell you, 30% of the stock is shorted. An Alzheimer's drug is worth $10 billion. It's trading at 200, so it's a 2% chance of success. A lot of red flags, but you know, I guess I'm the dumb one. You know, cassava, galectin, I mean, literally the dozens of biotechs. It's always the same story. And again, no matter how patiently or carefully I try to explain myself, it never changes a single mind.